Buenos días.
Good morning. Can you hear us well? It's a pleasure to welcome you to this seminar on the progress of the perinatal information system in the website version, also known as SIP+. I'm Dr. Giselle Tomasa. I'm a gynecological obstetrician, and I'm chairing the information perinatal system in PLAP. Next, we will hear Dr. Andres De Francisco, Director of the Family Health Promotion and Life Course Department in PAHO, who will open our seminar. The floor is yours, Andres. Thank you, Giselle. Good morning, everybody. Thank you for being with us today in this seminar that for PAHO and for Latin American Perinatology Center and the Family Health Promotion and Life Course Department I head is extremely relevant. As you're aware, the perinatal information system, known as SIP, is a highly extended system in our region that has proven benefits and strength throughout its nearly 40 years of life, as it was launched in 1983. SIP Plus is the website version and improves and enhances the already known benefits. This version is already being used by many countries, some of which are here with us to share their experiences and will able to tell us firsthand about the advantages of including this system. Of course, the COVID-19 pandemic showed the need to urgently count with open access to online data and critical information registries for decision-making and rapid interventions that are timely and effective. But this goes beyond the pandemic and is increasing quality in patient health care and access to information to formulate public policies that is essentially the basis for technical cooperation in our work with countries. The goal of this online meeting is to inform health professionals on the potentials of SIP Plus as a tool to improve maternal, perinatal health and sexual and reproductive health via the timely use of information gathered throughout the healthcare process available in real time. Throughout our meeting, we will hear about the following: basic concepts of interoperability and compatibility of SIP Plus with the digital systems implemented by e-governments in countries in the region. Successful experiences in the implementation of SIP Plus in countries in the region and matters of adapting it to the pre-existing e-systems. Experience of a team of neonatologists that will speak of the capacity of SIP Plus to generate predictive models using the databases and adding artificial intelligence and new functionalities that the system offers and automatic reports with one single click. And last, future training and new applications. We hope then that this meeting will encourage us to use this tool and continue working and exchanging experiences on the possibilities that the system has for each of the countries in our region. Thank you very much for your time. I wish you the best seminar and a good day. Thank you, Giselle. The floor is yours. Thank you, Andres. Well, an announcement for the attendees that we have simultaneous translation available both in English and Portuguese. Next, due to work reasons that don't allow her to be together with us today, we will hear the welcoming words of our director, Dr. Susan Cerruja, left recorded to share with you. Good morning, everybody. You're very welcome to this webinar. We have prepared a meeting to share with you the progress made, the innovations in the perinatal information system, not only from CLAP, that is the coordinators of SIP, via Dr. Giselle Domaso, or the maternal health areas, neonatal health, and sexual and reproductive health areas. We're going to show you where it has more interest, and that is from the countries Argentina, Uruguay, and Trinidad and Tobago, that will share their experiences that strengthen the best features of SIP: interoperability, the capacity to prepare national reports, and strengthen or capacity building for research. We want you to be aware of the system and the possibilities for improving on planning for care to women, both pregnant and newborns, and assess adherence of professionals to what we call cost-effective interventions. How many of us, for example, practice late clamping of the cord? This practice doesn't require any major interventions. The teams at the time they receive the newborn must wait to see the cord stops beating, and this is of fundamental importance in the first days of the newborn. We measure this in SIP with a variable that allows managers to modify practices within care to newborns. This example shows the importance of gathering data to transform them into information, evidence, better training, better care, and better indicators. What we are always seeking is to improve on the training of the health staff and thus facilitate to make the life of women and newborns not only healthy, but according to the full potential development. So you're very welcome to this webinar that will be uploaded to the PAHO website and in YouTube forever. So you're invited to enjoy this morning, where you will hear excellent presentation. I also wish to thank the countries that have made available their experience and that will be with us with their consultants. Thank you so much for being with us this morning, and ask you to disseminate the fact that we have this webinar for those who have not been able to attend live and participate. So discussing it in the workplace and sending it to colleagues both in the country, in the workplace, at hospital, so that they all become aware of these experiences and all the innovation we have prepared in the technical areas for maternal, sexual and reproductive and neonatal health. Thank you very much. Enjoy the webinar. Thank you. Due to time reasons, we have prioritized participation of countries so that they let us know of their experience with the perinatal information system. That's why I will only take a minute of your time so that you become more knowledgeable about the IT system I coordinate. Allow me to share my screen and share with you then the SIP team. Here then, this picture was taken last Friday during one of our weekly coordination meetings, and there you have the engineers Marcelo Rubino and Aldo Massa, our well-known expert in IT, Luis Mainero, and myself, chairing, but of course the main parts are they? As you may see, it's a small team, but very strong and that really love to work with the countries to improve the perinatal information system. I just wanted to share with you also that we're not alone, because we have the aid of 3 groups of friends and colleagues that are always contributing to the perinatal information system. Mercedes Colomar, coordinator of the Maternal Network for CLAP, Melina Pais, that organized all this seminar, expert in communication, thank you, Melina, and Gabriela Trujillo, that is helping to implement SIP, particularly in the English-speaking Caribbean countries. Last but not least, to remember our dear Gerardo Martinez, that would be celebrating his birthday today. As many of you know, Gerardo was somebody that really pushed forward the SIP. So we also thank his wife and family for this beautiful picture they shared with us so that we could share it with you. Without further ado, please, could you mute your microphones if you're not speaking for everybody? Now then, let's share the presentation made by our colleague Luis Mainero, known to all. The floor is yours, Luis. Thank you, Giselle. Can you hear me well? Indeed. And can you see the presentation also? Good. Well, I also recall our dear friend and colleague Gerardo Martinez. My presentation, as Susan mentioned, well, maybe you are aware of part of it, but I will be brief. I count with your understanding, so we give more time for the colleagues in the country. So briefly, I will divide CIPLUS in 4 areas. I will speak of clinical records, reports. We have new things, integration model, because gradually it has increased in consultations. And briefly, for those coming for the first time, I will speak of some things we have for the near future with SIP.
Como todos ustedes saben, se cargan en esta versión de C++, se pueden cargar desde un teléfono celular, de una tablet o de cualquier computadora sin importar.
Or any computer, regardless of how small or large they are. What is the idea of implementing C++ like this? Well, to be able to send the data to a centralized server at the Ministry of Health, or in some countries, as is being used in provinces or regions, to be able to send the data in real time if there is internet connectivity. And if there's not, as some of the colleagues will later on tell us, C+ can be used offline, and then automatically it is sent to a centralized server as soon as you get connected. It works similar to WhatsApp. You may write a WhatsApp message whenever you want, and then afterwards, when you get connected, it gets sent. So in the places where there's no connectivity, you can also install SIP+. Now, what is the basis of having a centralized SIP like this? The idea of having it centralized this way is that it may talk and get integrated with other health systems. That is, to be able to talk with the live birth certificates, with violence, with, as we are going to listen later, civil identification, vaccines, immunization, or everything related to course of life. Absolutely all the existing systems at province level or at the national level can communicate with SIP+. Likewise, we are developing some additional apps that have been designed for women. These are mobile apps that women can download from the app stores, and part of the system also includes this communication with patients. That is, SIP Plus enables you to get integrated in the health system under the umbrella of e-health, and to be able to share information as long as you ensure security. Well, the security of SIP Plus is very good, although everything can be improved, but you can have an integration of all the systems. Now, what can you do with the SIP Plus system in terms of integration with the ministries of health systems? Everybody connected today knows SIP because of the perinatal clinical record. Now, SIP has other modules of clinical records. One is the neonatal clinical record, another one for women undergoing abortion. Then there's one on congenital abnormalities and multiple organ failure that is used at CLAB for specific studies. One on Zika, dengue, and chikungunya. One is a community module. It's a module that instead of having the yellow squares or yellow circles, it has drawings for places where people find it difficult to read. So there's a clinical record that is integrated in SIP Plus that is based on figures. Now, this is just a bit of SIP Plus because when the COVID pandemic started, and I'm very honored of being able to share with you that in the first month of the pandemic, when the pandemic hit America, in the first month of the pandemic, CLAP had developed maternal COVID, neonatal COVID, and maternal mortality certificate. So this speaks of the speed of that CLAP has to respond to countries when they need it. I think that it is now clear, and I will dwell on this, that in order that the team, as she says, that we are just a few, but even like this, the software is designed in a way such that it can quickly incorporate clinical records. Now, we continue to work with the clinical records, and there are some new things. For instance, contraception, the contraception module, this is a kind of summary. There's another one on violence with a very interesting experience, very interesting in Trinidad and Tobago. There's one for immunizations that for COVID vaccines that monitors and conducts some analysis that I'm sure that other colleagues later on may expand on. And then just a short time ago, and this is an example, one on congenital abnormalities, a neonatal and for women undergoing abortion for Nicaragua. So the three latter are for Nicaragua. They are very, very recent, and that's why we include them here. But also other countries have asked for small changes that they needed to make the SIP compatible with their national clinical records. So that is why we introduced some changes in Argentina, Colombia, Nicaragua, Uruguay, Grenada, St. Lucia, Trinidad, Tobago, and some countries for which we developed a perinatal clinical record that is almost exactly the same as the regional clinical record, but with some small changes adapted to the country's needs. So in this presentation, you may see the clinical records within SIP Plus, when very often it is identified only people only think of the perinatal clinical record. The analysis, the power for analysis is very significant. We have the basic statistics report. That's a report that we have preserved in all the SIP versions. This report that you see here is in all the versions. It's always been there, and it has been updated after some years, because there are many institutions in the region whose indicators or whose comparison are done based on this report. That is why we have preserved it in all the versions. However, we have also added other reports, such as communicable diseases that include HIV, syphilis, Chagas, and hepatitis B, Robson's indicators with its 10 categories that are indicators that are shown in trainings, because they are very complex, and in just one click you have Robson's 10 categories in C++. And I'm showing small screenshots, such as the report of indicators for communicable diseases have several pages, but this is just a brief part of the report. Then there's a chart for Robson's categories to see the evolution of the different categories as years go by. It's a very interesting chart. It is also available in C++ in the latest versions. We've also added perinatal results. I'm sure that the colleagues will mention them. Indicators for women undergoing abortion, or and indicators for near-miss. Notice that in the latest reports that I put there, we have all the working areas of CLAP, and very recently, very recently, we started to add some indicators of inequality that visually have that format. Of course, again, this is a screenshot. These reports are several pages long, but that gives you an idea. You add educational level and coverage broken down by years. These indicators are very interesting. We are going to discuss them later. These are some of the new things that SIP offers in its latest versions. For those of you who don't know these characteristics, well, with the indicators report, we saw the same thing happening as with the clinical records. There are some countries, Argentina, Bahamas, Dominican Republic, Trinidad, Tobago, and Uruguay, that requested us, based on the requests of the ministries of health, whether we could include the one-click reports, adapting them to the country's needs. And hence, we designed tailored reports for those countries. So this is a brief summary of the many one-click reports of A+, but those of you who don't know the tool will have an idea of what you can find in SIP. So recently we've worked at, I'm sure that they will mention this in some presentations, some learning models. I'm especially interested in this. With the existing databases, some countries have several years, 10, 20 years worth of data. I think that we are at a time with this these analysis that we can make attempts to give you some reports to receive suggestions on the software that would go in line with what De Francisco and Susana said initially. So, as a summary, it has over 2,500 automated health indicators in over 30 indicators reports. If we consider all SIP+, it has over 3,200 variables for analysis in over 30 clinical records. That gives you an idea of the size of SIP+. And you have to add all the training online in person. The online courses are very advanced. There's going to be one online so that you may have access to these contents. There are manual videos in our website that I'm going to show you later so that you can register. So that gives you a summary of SIP. So SIP has integrated a number of things, and this has been requested increasingly. I'm going to give you 3 examples. I won't give you the details, but I want to show you an example in Trinidad and Tobago on violence. Then in this presentation, I show a model of integration of SIP Plus related to a national medical record in Trinidad and Dominican Republic. And finally, I am showing a project that we have worked on in Uruguay to incorporate the live birth certificate, the part of the perinatal clinical record in this live birth certificate. So these 3 examples are very clear examples of integration between SIP Plus and other systems. And finally, let me tell you what we are doing now. Marcelo Rino, who's also connected, he's part of our development team, is working. We are working developing a software for women to carry in their phones and have access to contents and their medical record. And I highlight this, have access to their medical record if enabled, not to make any changes, but to have access. It would be the equivalent of the perinatal card. And there, women would be able to access contents if she has any concerns. In addition, in the third image there, on the upper part, the software would certainly have 2 icons to trigger a call as an emergency if the woman doesn't feel well, if she's in the street, or so that by pressing one part of the screen, she would be able to make an emergency phone call for demanding care. So quickly, this is what I had to show you. So as conclusions, SIP offers all the management part, centralizing the clinical records in real time. And if it is effective, you can make adequate decisions. Specificity, each model country has a personalized system. You can analyze all the data, communicate with the different stakeholders, and it anticipates the ability, you can anticipate what it will happen in the future based on the data available, time reduction, equity, because SIP somehow ensures that the health information for the most vulnerable populations, and it is free of charge because it is absolutely free of charge, both its development and its maintenance. So Giselle, I think that we are in time now. So now I would like to recognize the dear colleagues of the countries.
Luis, muy buena la presentación.
Thank you, Luis. A very good and clear presentation. Next, I must tell you that we selected 3 countries with good experience using the system. They will let us know about the pros and cons they surely had when implementing the SIP Plus in their countries. It's a pleasure for us to first introduce Andrés Bolfan from the Perinatal and Childhood Department in the Ministry of Health, Argentina, who will share with us today actions and major progress made in the implementation of SIP Plus in Argentina. Please. Well, first, thank you so much for inviting us. I will briefly tell you about the history of SIP in Argentina. For us, SIP is the priority perinatal health tool. Argentina has a history of at least 30 years with SIP, and at present is it's one of the most valuable sources of information in the country. Of course, when SIP appeared in the internet version, SIP Plus, this was a very interesting challenge, so we could design a national strategy, because Argentina is divided into 24 provinces that are nearly like 24 countries, because they have a certain autonomy. So in the Federal Ministry of Health, we try to adapt the provinces so that we can have a joint national strategy. Essentially, in Argentina, SIP today is being used according to three main axes. First, an extension of coverage in SIP, and I will briefly show you how it developed in the past years. And for this, a strategy followed was with regional workshops. By this, we mean workshops where many provinces or districts gathered to jointly work with the perinatal information and learn to use SIP. This led to the second item, that's training and dissemination of the tool. We work with operational manuals, remote assistance, and others. And then the information element, including the SIP information. So it's not only an individual clinical record, but a national strategy. Here, I will show you the course of coverage of SIP in Argentina. By coverage, I mean that of every 100 births in the public hospitals of Argentina, how many are integrated to SIP? And starting in 2012, we had a floor of 70%. Every 100 births, 70 are in SIP. And among these 70, we have all the large hospitals in the country, all. I mean, the ones with a larger level of complexity. So the 73% coverage. However, this coverage is differential and responds to difference in each jurisdiction regarding the complexity of hospitals. Everything produced in the past 10-15 years with SIP is correlated in the national strategy with the production of manuals for operators, and by this I mean SIP users. As you may observe, we have some examples of SIP Plus as a recent tool and as the SIP that has been used in the country, and now SIP 2000. We produce a series of handbooks that are translated into information. Here we have one of the covers for 2021, basic perinatal indicators for management. We have a model in Argentina, we have annual reports, and this allows us to have statistics according to jurisdiction, to have the mosaic of perinatal information in the country and historical series. For us, SIP Plus is a very expected version of SIP, and we have 5 steps we designed at national level to implement it. First, to work with the provinces to have servers there, not a national one integrating all the information for each user, but rather that the provinces continue being the managers of SIP as to date and making copies for the national server, administering uses and roles of the provincial teams, and developing web services, because the provinces have different manners of managing the clinical records. So we respect the autonomy, and in this way they can integrate their clinical provincial records and SIP Plus. This goes hand in hand with training, and then an important issue that is importing the historical databases. Here we have the national SIP Plus. We receive copies from the provinces. This is functional since last year, and the status of SIP Plus implementation to date could be summarized in 4 stages. We have jurisdictions using and that have replaced SIPWIN with SIP Plus, others that have installed it in the provincial server and having pilot tests, and then jurisdictions with SIP+ installed that are trying to provide web service, and then jurisdictions that are familiar with the tool that had workshops but are deciding how to change. In this table, we have the name of the jurisdictions or provinces, the status of each, and today we have 70% of provinces where we had workshops that have SIP+ installed already, or with pilot tests, or using SIP+ directly, having replaced SIP when. This is a map of the country. In all the 24 provinces, we had SIP+ workshops, and some are working with it that replace a previous version, and others where they're doing the pilot test. There are experiences of integration. This is an example, Neuquén and San Juan, that integrated the web manager of the clinical records with SIP+ via a web service, and furthermore, they have a microservice that allows mapping in the SNOMED terminology together with SIP, so that physicians and obstetricians working with SNOMED may exchange data via SIP. Coming challenges, and we end here, the pilot test being made in the provinces to replace SIP-WIN, the development of web services that are very important at national level, and ensuring national replicas of copies were receiving from the provinces using Web+ in the national server, and developing new training resources, and particularly remote support. That is extremely important. This is an overview of what is happening currently in Argentina. SIP-WIN has been in all provinces for long years, SIP+ in approximately half functioning, and we're developing specific web services for each of those provinces. Thank you. Thank you, Andres. Excellent presentation. Next. Before hearing our next country, we'll share a short video with some aspects of the Panama experience. The perinatal information system is a very useful tool that allows us not only to observe the maternal mortality prevention indicators today, but helps us more, allowing us to assess near misses and seeing the children. And of course, all this must impact on the country's public policies. In Panama, quite recently, we have an executive decree where we initiated the filling of the SIP+ in a mandatory way for public and private units. It's a valuable instrument for country indicators, but in a very direct way allows us to prepare strategies that in turn shall become public policies in the prevention, in this example, perinatal and maternal deaths.
Trinidad
and Tobago is an example of SIP+ implementation in the region. They, more than anybody, will be able to share with you information about the capacity of interoperating of the perinatal information system with other health IT systems. That's why it is they that will tell us about their experience. Now, Seda Mohammed, Director of Women's Health in the Ministry of Health in Trinidad and Tobago, will tell us about the experience in the country, and two major collaborators of the CIPT, Isla Garcia and Aubrey Mendoza, will tell us about their experience in implementing SIP+ in Trinidad and Tobago. Thank you. Seda.
Hi, good morning, everyone. So my name is Sada Mohammed. I'm from the Directorate of Women's Health in the Ministry of Health, Trinidad and Tobago. And I want to thank CLAP and PowerHoon team for the opportunity to share Trinidad and Tobago's experience with implementing SIP and SIP Plus, to share a little bit about how we have used SIP for decision making, how we've modified SIP for our needs, ultimately with achieving the country's overarching goal of improving maternal and perinatal care in Trinidad and Tobago. So I just wanted to talk a little bit about why we needed SIP. And that's because over the period 2010 to 2015, as you'll see here, we were experiencing high maternal mortality, and ultimately we did not achieve the then Millennium Development Goal 5 for reducing maternal mortality. We had no perinatal information system at the time, and it was recognized that such a system was needed if we were to be able to ensure that all our pregnant women were getting quality care. So on this slide here, I've just provided an overview of some key moments in our now 7-year journey. So we started in 2015 that we've had in implementing SIP and SIP Plus. And just two things I wanted to highlight here were that in 2018, the Ministry of Health gave a mandate to all public health facilities to implement SIP. And in 2020, we would have started our transition to SIP Plus. So we've had some challenges, of course, over past 7 years on this journey, and some similar to the ones that were just shared by our colleague in Argentina. In Trinidad and Tobago, we have 5 regional health authorities, and they are autonomous in their operations. They vary slightly in service delivery. So because of that, we've had slight differences in implementation with SIP and SIP Plus. Some RHAs were able to progress to SIP Plus more quickly than others. We also have differences in implementation between primary care and secondary care. But because we have the mandate, we do have all facilities using SIP. In the initial stages, we had some challenges with revisions, the old forms, which we don't see that much now anymore. What we do see is some challenges with ensuring that we have complete information on the forms, but actually the transition to SIP Plus has helped with that because of the alert systems that are part of the platform. So it ensures that the providers put in valid data in the record. Another challenge we have is the private health sector, where 10% of our births occur. The majority of private health facilities do not use SIP. So we have no data on those women and their babies at a national level, and we don't know about the quality of care that they would have received. But despite this, we have made great strides in implementing SIP, and it's because we focused on 4 main areas: training, provision of equipment to the health facilities, strengthening the IT environment by installing a national server. We of course focus on change management. Our success with implementing SIP is largely because we have gotten the health sector to realize and recognize the importance of SIP and what it can do. So at the highest level, we have a Minister of Health who supported SIP implementation from the beginning, and he continues to advocate for SIP nationally and internationally. We created a unit in the Ministry of Health that is dedicated towards overseeing the implementation of SIP in the public healthcare system. And we have also gotten healthcare providers to recognize that SIP is a useful tool for assessing the quality of care they provide. And lastly, but I think most critical, key to our success has been the overwhelming support from PAHO and CLAP by means of the ongoing technical assistance, assisting us with infrastructure, resources, etc., to implement SIP. A couple of speakers before would have highlighted the importance of training, and we ourselves recognize that the staff must be properly trained to use the SIP to ensure that we get the correct data to make our decisions. So in collaboration with PAHO and CLAP, we would have had numerous virtual and in-person training sessions, but the Directorate of Women's Health also wanted to explore other possibilities and other avenues for training to ensure that we were reaching as much of our healthcare professionals as we could. And some ways that we have done that are to introduce SIP training for medical students in the universities. We have started holding national SIP resensitization sessions, which are led by our own healthcare workers. We call them SIP champions. And we have also introduced a national online learning management system where we make recordings of all the training sessions available so that providers can go onto the platform and look at the sessions in their own time. So how have we used SIP for decision making? Since implementing SIP, we now have real-time access to data for decision making. And one of the earliest examples of this was that SIP actually allowed us to see that the majority of our pregnant women, roughly 85%, were presenting to antenatal care for the first time much later in their pregnancies than recommended, which was the first trimester. And that would have led the Ministry of Health to take action and intervene. The Directorate of Women's Health would have started developing a series of patient information materials to sensitize women in antenatal care. And the Minister of Health made several public appeals to pregnant women to present to antenatal care at the recommended time. Because we have SIP, we now have readily accessible data on high-risk pregnancies, of course, which is needed to reduce maternal mortality. With Trinidad and Tobago, we have an estimated 1 in 5 pregnant women who have hypoglycemia in pregnancy. And the Ministry of Health would have developed clinical guidelines for diabetes in pregnancy. And we are now able to use SIP Plus to help us monitor the implementation of those guidelines. So here we have some data from one of the regional health authorities on screening for diabetes in pregnancy. Diabetes in pregnancy has actually been a priority area for Trinidad and Tobago, and we embarked on an IDP project to improve maternal outcomes in women who have diabetes in pregnancy. And a key part of that project was ensuring that we were capturing the relevant clinical data to make decisions. And we wanted to capitalize on the interoperable and compatible nature of SIP to do this. So here you see that we have actually modified that page 1 of SIP to now include an automatically generated SIP Plus number, which will synchronize with lab information systems, as well as any other systems that may come on board in the future. And when this is printed, it actually generates a barcode so that the lab staff can scan the barcode and have easy access to patient records when they receive a request. We also wanted to tailor SIP to ensure that the clinical data as prescribed in our clinical guidelines were being captured. So we have worked with CLAP and PAHO to modify the SIP Plus platform to capture OGTT results, as well as fasting blood glucose results in the notes section. And we worked with them to have alerts generated so that the provider can easily see when a value is too high and can ensure that the patient receives appropriate care. And lastly, because SIP is an excellent tool for research and audit, we are now able to filter some of the reports that Louise would have talked about by OGTT and FBS results, so we can generate specific reports on those key indicators for women who have diabetes in pregnancy and use the data from those reports to make decisions for their care. So another priority for Trinidad and Tobago is the elimination of violence against women, and Louise would have mentioned this. The Office of the Prime Minister actually had seen a demonstration of SIP Plus and what it could do, and we're interested in using the SIP Plus platform to collect data on gender-based violence. So again, we would have collaborated with PAHO and CLAP, and we have now developed a SIP Violence Against Women module that you see here on the right, which supports our first ever national clinical and policy guidelines on intimate partner violence and sexual violence. And we are in the process of rolling this out. So at present, in Trinidad and Tobago, we use a mix of hard copy SIP and SIP Plus for perinatal care. We are in the process of piloting the modifications to the diabetes that were made for diabetes in pregnancy. But again, because of the flexible, the interoperable and compatible nature of SIP, the possibilities are really endless, and we would really like to capitalize on those and take SIP across the life course. So our future work is really focused on, of course, SIP Plus in all public health facilities, rolling out the Violence Against Women module. We're currently in discussions to introduce SIP for neonatology, and we'd also like to use SIP to monitor breastfeeding and child health. So on behalf of the Ministry of Health, I would like to thank PAHO and CLAP for the opportunity to showcase our pioneering work, because it has been a collaboration since the start. And I'd like to thank them for their continued support in helping Trinidad and Tobago improve maternal and perinatal care. Thank you.
Bueno, muchas gracias, Ada. Estamos un poquito cortos de tiempo.
Thank you. Thank you for your presentation. Unfortunately, it's rather late, so we go directly to hear the presentation in Uruguay. You know that SIP is mandatory by law, and it's been so since 1990. The Ministry of Health uses SIP as an instrument to monitor compliance with the core targets, and since 2006, the data are available on the website and anybody can process it online. Today, the Clínicas Hospital has been the first one to implement the web version. So now we have Fernanda Olacina of the Clinic of Neonatology of the University, who will talk about the capability to predict for predictive models in health. Good morning. Thank you for inviting us to participate in this seminar. And I especially want to thank Giselle Tomaso and Luis Ainedo. We're going to talk about the capabilities of SIP Plus to generate predictive models, showing the work that we conducted in a recent publication in collaboration with other centers from the United States. In this case, the concern for generating algorithms for the prediction for clinical decision-making led us to use the statistical model of machine learning so that with open source language, software language, we could develop indicators, low-cost clinical data, essentially using anthropometric, non-invasive, and inexpensive indicators that are accessible in clinical practice. Specifically, we wondered what can be learned in clinical trials conducted in wealthy countries, and whether the information obtained there could be generalized to other eco-health ecosystems. So we used two series of data in cooperation with the University, Ohio University, with Dr. Otero. We managed to analyze a number of data from the PROP trial that was a trial that was available, has been available since 2010. A lot was invested there, $18.5 million in the United States, to improve strategies for the management of respiratory complications in preterm babies. I don't know whether you are sharing your screen. I am, because we're not seeing it. We are not seeing it. Let me see. Let's check now. Can you see it now? Yes, we can now. Yes. There. Yes. Yes, perfect. Okay, so Here we present the work that I just mentioned that was published recently, and we were describing the type of data that we used for analysis. So first of all, with data from the PROP trial, which included preterm babies born from 23 weeks to 28 weeks, 6 days, from data collected from 2011 to 2014 in 6 centers with neonatal ICUs, and we analyzed 813 patients, and we compared some of the analysis against a sample that was available based on the use of the perinatal information system at the clinical hospital that, as has been mentioned, is used as a mandate. SIP is used as a mandatory record, and the Ministry of Health has all the national records. And in the case of the clinical hospital, we've had records since 2001. For this sample, we incorporated patients starting in 2018. And we select from 23 to 30 weeks, and we finally selected 44 patients for the study that I'm going to share. So, from a methodological point of view, because of lack of time, I'm just going to show the core results. We use the R code, support vector regression model, and the patients in the PROP trial were separated into two groups. 70% of the groups were used for training on the algorithms, and 30% for the evaluation once we had the algorithm. And what we modeled basically was the daily head circumference, weight, birth weight, sex, and registered and sex, and the measures of the head circumference registered. So, and we modeled the daily weight. So in the PROP trial identified two key clusters based on these anthropometric indicators. And here to the right, you see the two groups of birth weight, gestational age, and head circumference that were clearly distinguished. In cluster 1, you see that the birth weight was higher and the head circumference was larger and a greater age. They had fewer complications. And in this case, these three indicators were significant predictors of the comorbidities in the early postnatal period.
Here we compared cluster 1 and 2, and cluster 2 showed a higher probability for different comorbidities such as retinopathy, sepsis, chorioamnionitis, maternal diabetes, lung bleeding, ductus, and lung hypertension. As part of this outcome, the morphometry was linked with respiratory dysfunction in the case of the PROP series. So, let us show the use this had as compared with a sample of Uruguayan patients. Using anthropometric data, we had a growth prediction model based on the PROP patient, and we'll give you just 2 examples due to time reasons, because we can't share all the data right now. Here you will observe percentile 10 and 90, and the blue and pink lines for girls and boys, and growth in the case of one patient that did not present sepsis and grew appropriately. And the growth prediction is this dark black line. At left, we have the case of a patient with proven sepsis, And you will observe that as compared to the prediction, that's the black line, the patient takes a distance from the prediction impact. And in this way, this was repeated. This is just one example, and we could confirm that patients with sepsis showed a growth curve below the predicted one. When we went to see what happened with Uruguayan patients, we observed that these predictions could not be generalized to other institutional environments such as in our country. Here, I will also show you one example of what happened with some curves for Uruguayan patients. This is one patient that died in the end, and the black line shows the prediction made according to the model. In blue, you have the weight at birth. As you may observe, the black line is quite distant from the weight when the patient died. When we conducted this analysis, we observed that in the early stages, the marked deviation from the prop prediction could be a strong indicator regarding the course or death, because patients systematically were quite far in the case of deaths. However, in the weight curve in children in Uruguay that were discharged, that is, survived, the prediction made with prop overestimated the real weight the child could have. And here we have this curve, this graph at left, where we must observe that 30 of the patients, approximately, remember they were 44, showed a difference of 500 grams on discharge as compared to what had been defined by the prop and what truly occurred, because here we have the difference between actual discharge weight and predicted weight according to the algorithm. Therefore, we conclude that in silico biomarkers based on anthropometric measurements could be established. An increased probability of sepsis was indicated in patients below the expected growth according to the model. A promising algorithm was also generated to identify a poor course, particularly death, in the Uruguay series. The Uruguay data sample evidence that generalization of models is poor. The reasons may include different nutrition protocols between the US and Uruguay, different incidence of diseases, maternal factors, among others. And it's clear that we have a need to invest on clinical local information programs, and this is key. And in the case of Uruguay, we have SIP Plus at the clinical hospital since January this year. The work has been well coordinated among the IT team in hospital and at CLAP. And of course, counting with databases that could be reanalyzed, as in the example shown, is fundamental to apply machine learning. So we must promote digitalization of data and their interpretation at local level. And of course, at present, we see apps with automatic learning and artificial intelligence components that will be able to create private, safe networks so that large scale health data may be analyzed. Thank you. We're open for any questions. Thank you, Fernanda. Lovely to have your presentation. That was very clear and very useful to consider other applications for SIP. Next, Dr. Bremende Mucio, Regional Consultant in Mental Health for CLAP, will show the capacity of the SIP in the web version, the plus version, with a single click, what we call the one click wonderful automatic reports for near miss, broken down according to inequality indicators with graphs for better interpretation by clinicians. The floor is yours, Bremen. Thank you, Giselle. I think your presentation was too good and it generated great expectations regarding what I will ultimately share. First, I want to publicly thank Dr. Germán Gallego, who helped me to make this presentation, and who's the consultant we have hired in club to prepare this design for our indicators. Our idea is to have this automatic output so that people not familiar with near miss may have the indicators. Of course, we train people to better understand what a near miss is about, how we gather information, the impact this may have, and how to act so that near misses don't end with maternal death. And at the same time, we want to have less cases of near miss, but we've entered into a different dimension, as Giselle mentioned, regarding the analysis focusing on equality, because as you are mostly aware, most cases of maternal death and also extremely severe maternal mortality or near miss are cases where women have a large number of vulnerability factors, and that's why it's good to have this sort of analyses that have been developed and that you can count on. That is why, according to this rationale, we've worked with 3 instances. One, bearing in mind the road to survival or death, starting with preventive actions, identification of risks, how to conduct different interventions, management of obstetric complications and the impact on maternal near miss, and how these severe complications are managed, because it is specifically within this major spectrum of complications that some threaten or potentially threaten life, and some, of course, end in death and are related with these complications that occur in the case of maternal near miss. And last, the most complex case you have in yellow, and that's maternal death. However, we've conducted analysis in different ways. We have broken down the causes for maternal near miss into 3 major groups related essentially with a relationship with the direct causes of maternal death and also of maternal near miss. So we've focused on the identification of hypertension, infections, and bleeding. And on the one hand, we've indicated these stratifying features that allow us to consider the different issues in the different layers. We have mother's age, ethnic group, and educational level. We would have liked to use income and have the population of a health facility or region or municipality, country, identified according to quintiles of income. Unfortunately, SIP doesn't gather this information, so we can't do it. Here, I'm going to share in summary the metrics of inequality we've decided to use and the estimates that are very complex but will be obtained with a single click. One is related to the reason for the risk, and we'll enter into each the inequality index. And when you enter into SIP, you find this screen where you place your identifier and password. And when this screen opens at right, you will have the different reports. In the upper part beside the globe, we have the languages, but you can use any language that is used in the region. When you go to the report option and click there, you will have this menu. And here I selected near miss SIP indicators that are new indicators, but these aren't the indicators for inequality, but the traditional indicators, and will be available at one click and will be compared with the different years in your department, region, and country. Here we have indicators for SIP, and there you will have a list such as this. In the upper part, you have the total number of cases included in that database. We're updating. This is a CLAP network for near-miss surveillance, and here we have close to 14 hospitals in 10 countries in the region, but there you observe it's over 150,000 cases included, and you have these traditional indicators. The reason for the near miss, in this case, 4.43 per thousand, and the mortality index, the near miss ratio, and the criteria case ratio. We're not going to analyze them right now, but we may do so. And indeed, in all the workshops performed and lectures by the SIP team to identify maternal near miss, we deepen further in those areas. If you go back to report, you will see one related with inequalities in health data according to educational level, ethnic group, or maternal age, as mentioned before. In this case, when you select, you have the screen with a related report, and in the first part, you have the characteristics of the database selected, 2, the indicator, and 3, how it's created and what it means. I want to add that we also developed a deeper manual to interpret in further depth what each of these indications means. When we go down in the report, we have this table that speaks of the reason for maternal near miss. In this specific case, according to education level, the first line shows a global near miss for the institution. This column in this specific database, as the one I have, where you have the global data, 325, and the data as it's behaved during the past 5 years. And here in the second, third, and fourth and fifth columns marked in the second chart in red, what occurs according to primary school, secondary school, or university level education, or none. And last, well, this is a second column mentioned, the reason for risk, while you have the disparity index and deviation among groups, that is, the variables you will automatically have. And as shown by Luis before, I'm going to show you another graph specifically related with an equiplot of the reason for near miss in this database according to the educational level.
And then you can see different things, except for 2020, which may be a bit confusing. You see how the university level is the best level, and in those cases, the maternal near miss ratio is shifted to the left towards the years. That is typically the lowest. And you can also see an absolute gap separating the different groups. So you can see in 2019, the huge gap there was between the people that had university level and those with no education in the case of maternal near miss. But if you want, if you wish, you also have this represented in this risk in this odds ratio. We use this as a relative measurement of the gap, and we estimate it as the ratio between the least favored group, in this case, none, 5.07, based on, and versus the most favored, that is 2.79, and the ratio is 1.82. And you see how it changes, how the ratio changes. So you see that the women that had no education have twice the risk as compared to the university graduates. And you know that this disparity index, that we can discuss it later on if you wish. We have the manual that is available, but this is a measurement that is no longer absolute. It's a relative measurement of inequality where the percentage expresses a gap, the difference of the least between the least favored and all the rest. So in 2022, probably related to the pandemic, COVID-19 pandemic, you see the huge impact that led it to 565%. So this is absolutely crazy. And finally, the intergroup shifts or deviations expresses the deviation of the results of the indicators measured in each of the strata with respect to the overall data that is there in the first column, 325, 173, 239, etc. And this implies that you can underestimate these differences. So you have to be very careful when you're working with small groups. And that is why it's so important for us to work with larger samples. Sometimes for a hospital with just a few cases, you know the statement gives such a relevant information. However, it is very valuable when the hospitals are larger or consolidated at a municipality level or community level. Now, be careful because somebody was asking whether this could be used at a primary level. Well, the case of maternal near misses are all hospital cases, and they typically occur in second level or more complex hospitals. So this information in the first level of care will not be available because no near miss cases are loaded in the first level of care. My apologies that I went through this so quickly, but we had very long, short time. So I want to thank you for having paid attention and the organizers for having invited me. Thank you, Raymond. And now, Dr. Pablo Duran, Regional Advisor of Neonatal Health for a club, shows us the capabilities of SIP+ in obtaining automated reports for to see the outcomes and the results of neonatal health. Thank you, Giselle. Good morning, everybody. It's a pleasure to share these brief minutes, but especially having participated and having witnessed the previous presentations, especially seeing how the countries take advantage of use of SIP. So in these minutes, and I won't give a presentation, but rather I'm going to show the way it works. The idea is to highlight the significance of SIP for perinatal and neonatal health. As you all know, in the Americas, 15 million babies are born annually. So a bit more than a million are born prematurely. And we know that this is a burden of disease, mortality, and um, uh, disease that is very significant. And as Luis Mainero pointed out at the beginning of the session, SIP allows you both to consolidate information about healthy newborns and with newborns that require special care that are admitted into intensive or moderate care units. There's a special module, and the same applies to the newborns that have congenital abnormalities, because SIP is a core instrument with its module for congenital defect for the surveillance of um, one of the conditions that contributes to neonatal and child mortality. So as a second element to highlight, together with the burden of the disease or the number of newborns, let me now share the screen. As the second element, and this was mentioned by all the previous speakers, we know that SIP is an essential tool for clinical management in the care of each pregnant woman, each newborn, regardless of their condition, but also for the managers of healthcare services, and third, for the programming for decision makers. So in this, under this perspective, then trying to respond to newborns with different conditions and responding to the management needs from the clinical level, uh, uh, service management and decision making and the evaluation of policies and programs, it is that in terms of neonatal health, we have incorporated a number of indicators that you may obtain automatically, as I'm showing here on the screen. These are quality neonatal reports, have these 4 chapters: perinatal outcomes, quality of care, conditions at discharge, and analysis of inequalities were designed so that, based on the support that SIP gives the quality of care, may enable the managers of healthcare departments and maternity hospitals and decision makers. It enables them to take into consideration these core indicators. So let's go through these components. That this was already mentioned by Dr. Saruya when she in her opening words, and you see that some of them are key. The number of live births, um, stillbirths, um, uh, death during delivery, etc. How you can evaluate based on the moment of, of death and also the babies with low birth weight, gestational age, and and whether they're adequate, the weight is adequate for gestational age, and then their vitality score measured through the APGAR score. So very simply, you have some basic, some core indicators that gives us a lot of information concerning the critical neonatal outcomes in the neonate that is essential for decision making and management from the point of view of quality. And notice how easy it is that by choosing the category of the indicator that you want to process and clicking on issue report in just a few seconds. And this is a database that is recording over 140,000 newborns and pregnancy terminations. You can see a very significant indicator that Dr. Saruya mentioned at the beginning of the session about the implementation or lack thereof of the timely ligature clamping of the cord, and the implementation of a number of interventions for neonatal resuscitation. You see here that although 70% of the newborns required no actions, a significant proportion, especially, well, stimulation for as a first measurement, but the required interventions. And this tells us of the characteristics of the population receiving care, or the different screenings for prevalent conditions. In terms of conditions at discharge, the report enables us to evaluate how they are being fed at discharge. We know that prematures feeding, non-exclusive breastfeeding is a problem. And here you see that although 98% was discharged with exclusive breastfeeding, there was a percentage that was not. The screening, hearing screening, Chagas, disease, bilirubin, other communicable diseases or indicators that can very quickly um, alert decision makers or hospital managers to evaluate the situation of these newborns. And here you see, for instance, the reference close about, for instance, position at sleeping. And you know, you see that this is not always done properly. And as the last, we have the inequality analysis. In the case of neonatal outcomes, is having one parent and maternal education as the two stratifiers to assess the inequalities, then a low birth weight, prematurity, suboptimal APGAR at 5 minutes. So here you have what will happen with each indicators and these strategies. So you see, this is the idea that has prevailed in the design of these automated indicators. It is to facilitate the process so as to have information for decision making immediately, precisely for those professionals in charge of decision making, but who in turn this can be expanded to other indicators responding to specific needs of the countries. So the invitation is to approach, implement, and experiment with these indicators and to use them in the scoreboards, in the round discussions at different levels, so that in the monitoring you may evaluate gaps both from the perspective of inequality and also considering the distance between the current situation and the desired situation. So with this, I would put an end to my presentation. I would, and I wanted to thank the SIP group, both the software developers and the technical. Thank you.
Muchas gracias, Pablo. Y
Giselle,
finalmente,
Giselle,
Thank
¿puedo
you,
hacer-
Pablo.
El chat
Giselle,
estaba con un pequeño problema
the chat had an issue and now it's apparently solved. Just if anybody wishes to write down something. Thank you, Luis. Okay, as I said, to end, Dr. Rodolfo Gomez, Regional Advisor in Sexual and Reproductive Health for CLAP, will share the new SIP forms to register valuable information about contraception and violence and also reports for these two forms. The floor is yours, Rodolfo. Thank you. Good morning, everybody. Good afternoon, rather, in some places. I'll briefly let you know in a few minutes about some of the things that some colleagues have already mentioned. First, we'd like to share this good news from Trinidad and Tobago. There's a champion that created this excellent work to create national guidelines on intimate partner and sexual violence, but also ad hoc tools such as the perinatal information system in the violence area. This is a handbook used together with PAHO, CLAP, and the government of Trinidad and Tobago and a large group of experts. This was down up, demonstrating the variables the country had as a priority, and we followed the WHO standards regarding the response to gender violence in the health system. So we used international standards that are global and those proposed by PAHO and carried them to Trinidad and Tobago directly in the field to create this clinical record as shown by the colleagues, and I'm very proud to be part of the team that developed this conceptual part. And CLAP as a whole contributed in the different sub-areas to improve upon this clinical record that is already mature and ready to be implemented in the 5 health regions of the country. This clinical records, if you observe in the sector, has this theme. This is one of the few clinical records that is not related to pregnancy. So the perinatal information system, initially designed for pregnant women, includes this clinical record beyond pregnancy. And the two I'm going to show this. Here we can record where the injury occurs, who conducted it, indicators for quality of care, and the timeline. This is how it looks. It has these parts in light blue here that are a reminder for the health professional regarding how to start the dialogue. It's small innovations that allow us to have a sample of the degree of empathy with which the health worker must access and listen to the victims of sexual violence. And after gathering the data with all the confidentiality this requires and registering the different times of care, we may also obtain quality of care and reception of these women indicators. For example, the one-click report. Clicking on the intimate partner sexual violence healthcare report, we have the type of violence, a description, and then if the first level of support, where we assess the quality of care, has been established, if the care, the specific care, was delayed due to any reason, and essentially if there are any references in some indicators highlighting crucial parts of the automatic report. This is in English and has already been translated into Spanish and will be implemented in many other countries in the region, but the initiative started in Trinidad and Tobago, and it's an excellent example of how initiating an action in a country to solve a health need, we generate a positive movement. Of course, it's not only been translated into Spanish, but it will be tested as a pilot project in different countries in the region where they have this general global minute for responding to gender violence. Another element is contraception. That is also a clinical record that isn't recorded specifically to pregnancy or delivery or abortion. As you may observe, the core is based on medical eligibility criteria for contraception used at WHO. This is a 5th edition, and in 2015, we had the conditions, the health conditions that may be surveyed when contraceptives are used, and our clinical record uses AI based on these concepts for tailor-made needs for contraception in women, following the family planning guidelines of WHO and best practices based on evidence. We developed this clinical record model. Don't look at the charts, but you may observe they all have a familiar shape in yellow, risk, and so on. And the clinical conditions that women will present are shown in the different sectors of the clinical record. And at the end, we have in the lower part the group of contraceptive measures recommended for the women, type 1, 2, 3, and 4. 1, 2 are those recommended. 3 may be used if there isn't any another that is better. 4 is banned because it could generate a serious health event. So the clinical record records data, but also helps us to think and could help to include the rule or the table of choice for contraception applied as AI behind the clinical record.
De las variables nos permite elegir el mejor método.
So the proper filling of the variables enables us to choose the best contraception method for this woman. If there are some variables that are crucial have not been included, such as the presence of cancer, smoking, thromboembolism, that would lead us to change the contraceptive method. In that case, the system will tell you we can't evaluate it. So in order to evaluate it, we must fill it in garbage in, garbage out. If you don't include the data you need, it will be inadequate. And then and it has the course of the medical record. The woman may be invited to check the method she's using or her clinical record. And we have, for the first time in the perinatal information system, we have a gender area, gender and identity, that would enable the trans males that have a childbearing possibility have access to contraception and to be registered in this medical record. This is how we see the contraception medical record in the web. Here you can see all the variables that are filled in the same way as the rest of the medical records. And here at the bottom, you can see in the first part the categories 1, 2, 3, or 4, and notice that 3 and 4 are in yellow for the different groups of contraceptive methods. We evaluate what method is chosen by the woman after counseling and what she receives. So this will help us analyze the consistency between supply and demand. And there are several indicators that were also built based on an expert consensus, including WHO, Michael, and experts, Latin American experts, and experts from different universities in the region. And they described these groups of indicators. First of all, we describe the population in the program, then the contraceptive method used, analyzing it, stratified based on whether it is generated after an obstetric event or in the interval, and then we see the consistencies between whether the woman received what she asked, and we see the effective coverage of the method, and we also see whether the different stratifiers match, where such as ethnic group, place of residence, and here we can detect the most vulnerable populations and to enter them in quintiles, and we can see whether the woman is receiving government subsidy, if she works with a remunerated job. So this enables us to see inequalities. These are proxy indicators, as Dr. De Mucio pointed out. We can also evaluate the quality of the care provided, knowing what are the professionals that prescribe and insert the different methods. And then we have the automated calculations of the protected rates. This is stratified by ethnic group, education, civil status, and government subsidies. So these indicators will enable us to provide modern contraception and reduce the unmet need for contraception. So we would contribute to sustainable development goal number 3. In the name of the team of CLAP and the networks of Sentinel centers, thank you for your time, and we'll be very ready to answer any questions or queries you may have. Now, thank you, Rodolfo. The last slide especially was very nice because it summarizes. I wanted to tell you that because of time constraints, it's already late. And sorry, I was having listening problems. So we received many questions and we tried to answer them as we moved forward in the webinar. If any remained unanswered, don't worry, we'll do it as up. We're going to check all the questions and we are going to answer. Anyway, in the chat, you have our contact data. The SIP team is there, and we'll also send you the recording that will be available on YouTube. So it will be open for anybody who wants it, but also to the participants today. We had almost 400 people, so we are going to send you the link for you to see the complete video. On the other hand, I just want to thank all the speakers. There were wonderful presentations that they shared today, their experience with the use of the system. And for those of you who are interested, because there were many questions about it, for the implementation of a SIP in maternities, please contact us and we can give you advice showing how you need to submit your concerns. Remember that SIP is open source, and it is, you don't have to pay anything, and we wanted to meet you. And finally, I wanted to share one last slide announcing the presentation, the forthcoming presentation of a course, an online course. Can you see it? For the proper use of perinatal data, where we are going to explain the proper registration, how we have to enter the data and use the online analysis and how to obtain the one-click reports. And finally, we assess the knowledge acquired, and CLAP will issue a certificate, a diploma. So thank you. See you soon.
Gracias, nos vemos.
Thank you. See you.